In today's video, we're talking about terms like seminal vesicle invasion, perineural invasion, and extracapsular extension. Sometimes we see these terms, whether that be on pathology reports or imaging results, and we kind of go, what does this mean? Does this mean I have a more extensive type of cancer? Does it mean I need more treatment? What treatment will be effective? So today we're going to ask Dr. Mark Schulz. He's a 30-year medical oncologist who is focused solely in prostate cancer. And we're going to talk to him about these terms, what we can expect the outcomes to be, and what will be effective. So today, Dr. Schulz, we're talking about seminal vesicle invasion. And I think a lot of times patients get these results back. Maybe it's from imaging, maybe it's pathology. They're trying to figure out what type of prostate cancer they have. But then when they see an imaging result in their seminal vesicle invasion, or maybe they had a treatment and that comes back on their report, there's great cause for concern because invasion is a big word. For us who are not trained in the medical field, we don't know what this means, and it can cause a lot of fear. There are different types of prostate cancer, but if we see seminal vesicle invasion, how much cause for concern is there?
All the pathology that we get back in pathology reports, seminal vesicle invasion, extracapsular extension, perineural invasion, these descriptives were created a number of years ago when we didn't have PSMA PET scans to determine if there was any spread. And so we used those factors plus how high the PSA is and how many cores are positive to try and profile people based on many other people that have come before and who later turned out to have some spread. So you could work backwards from that. So let me just paint a little scenario of how this used to work and how it's changed now with PSMA PET scans. Microscopic spread, or spread of any kind, is the biggest, most important factor with prostate cancer, other than maybe hormone resistance. But it starts with spread almost always before you have hormone resistance. This question of spread is what the industry has been trying to work out for many years, again with a profiling process. It works backwards from someone who has surgery or radiation and the tumor in the prostate is successfully eradicated. The cancer never comes back in the prostate area or in the prostate itself after radiation. Unfortunately, in a percentage of people over time, even though they had a clear CAT scan and a clear bone scan, a percentage of the people will develop a new spot somewhere else in the body. And initially that's confusing to people. They said, how could a new spot show up? We got rid of the original spot. And the answer is that at the time that the original spot was there, even before the surgery or radiation was done, a microscopic speck of cancer has spread into a lymph node or the bones. But it was so small it couldn't be detected, but over time grew large enough to be detected. And that's the relapse that we're talking about. Well, it turns out you can predict how likely an individual who's about to have surgery or radiation is to have a microscopic speck by profiling them compared to other men that later developed specs. So you can go back and say, okay, 100 men had surgery, 20 of them developed a lymph node. And if we look at the profile of the 20 men that had a lymph node, what their Gleason score was, whether they had seminal vesicle invasion, extracapsular extension, all these other different factors, you can see a pattern where those have more worrisome findings, the ones that develop those microscopic specks that later show up as a relapse. So that methodology has been in play for 30 or 40 years to try and decide if an individual should have radiation to their lymph nodes as a precaution, whether they should have extended hormone therapy for 18 months to try and eradicate microscopic specks. These interventions have repercussions. You don't want to do them in people that don't need it. So circling back to your question about seminal vesicle invasion, that historically was associated with a higher incidence of microscopic spread. This issue, in my mind, as of 2024, is not as dire a concern in someone who has a PSMA PET scan that doesn't show any spread. Absence of spread on a PSMA PET scan is not a perfect prediction of no spread, but it's a healthier, more accurate one than what we previously had with CAT scans and bone scans. Seminal vesicle invasion is a sign of a more aggressive cancer. Before we had PSMA PET scans, it was a sign of a greater likelihood of microscopic spread, which is the real issue in cancer and of course with prostate cancer as well. But now that we have these PSMA PET scans, I am not as intimidated by seminal vesicle invasion as I used to be when we didn't have PSMA PET scans.
Before I get to my next question, I just wanted to remind you of a couple things. We do have a prostate cancer patient conference in person coming up this next September, and you can find out more at our website at pcri.org/conference. We would love to see you in person. Also, if you can donate to our cause, you can do so at pcri.org/donate, and don't forget to subscribe to this YouTube channel. It's a great way to support us and get our videos out to other people who need help in the prostate cancer world. Now back to my conversation with Dr. Scholes on seminal vesicle invasion. This term seminal vesicle invasion, SVI, as you said, because we have PSMA scans and you're not seeing, hopefully, we're not seeing metastatic activity outside, we're really talking about it leaving the prostate. When we talk about localized prostate cancer, we aren't seeing, extracapsular extension. But I just want to break down these terms really quick. First of all, what is a seminal vesicle and what is the cancer invading into and what does it affect?
I think one of the other implications that needs to be discussed is that if someone has invasion into these seminal vesicles, think of it like little rabbit ears on top of the prostate is making seminal fluid, and where does that extra fluid go until a man has an ejaculation? It gets backed up into these little reservoirs, these little sacs on top of the prostate that swell up, filled with semen until a man has an ejaculation. And the idea that the cancer is growing into that area suggests a somewhat more aggressive cancer or a larger cancer. It turns out that with effective radiation therapy, it's not difficult to sterilize it or eliminate it. I think it is more difficult to cure it with surgery, and I would really question anyone that's going to have surgery to treat someone with known seminal vesicle invasion. I think they should have radiation, not surgery. But the main implication, as I already pointed out, is the possibility of its signaling, since it's a bigger tumor, therefore somewhat more likely to make microscopic metastasis. It does also have implications for disease control in the prostate and in the seminal vesicle, because I think it would be a mistake to have surgery. They probably won't get all the cancer out, and you're going to end up needing radiation anyway, so why not just go straight to radiation, which is sufficient for killing disease in the seminal vesicles.
So what about extracapsular extension? Are we just talking about leaving the prostate capsule? And if it does leave the prostate capsule within that term, extracapsular extension, does that mean it's going to the seminal vesicles?
Seminal vesicle invasion is a type of extracapsular extension, though the idea of the cancer getting out of the prostate into the seminal vesicles is one anatomic area. It is also possible for the cancer to be at the edge of the prostate and extend through the capsule into the immediate surrounding areas of the gland. I'll reiterate what I say about seminal vesicle invasion for extracapsular extension, and that is that these are the people that are usually bad candidates for surgery. They're not going to be able to do nerve-sparing surgery in those individuals. They'll have to sacrifice the nerves. There's going to be a much higher incidence of impotence, and there'll be a higher incidence of relapse after surgery. Whereas with radiation, extracapsular extension is easy. They just paint a little bit broader margin around that area of the prostate, and the cure rates should not be diminished in people that have extracapsular extension. There's also been studies showing that extracapsular extension per se is not associated with a higher incidence of microscopic metastasis. When you account for the other factors that we rely on, like Gleason score, percentage of core biopsies positives, the size of the tumor, when you take all that into the analysis, the presence or absence of extracapsular extension does not predict for microscopic spread.
What is this term perineural invasion? What is that affecting as well?
So perineural invasion is another factor that historically, as a standalone, could predict for the presence or absence of metastasis, but taken in the context of the other more important factors like how big the tumor is, percentage of core biopsies positive, pathologic grade, has really no predictive power. It is also associated with extracapsular extension because what's happening is that tumors are growing along the nerve sheath and they can get out through the capsule more easily. But since, as we already pointed out, extracapsular extension itself is not associated with higher incidence of metastasis after taking in all the other factors, perineural invasion is in the same category. It's a descriptive term that is associated with a phenomena that is not powerful enough to predict for the presence or absence of metastasis. One pathologic thing that has come up more recently is called cribriform, and this is the appearance of the cells themselves in this spectrum of using higher and higher Gleason scores to predict for micrometastatic disease. It turns out that cribriform advances you. So if you have a 3+4 that's cribriform, you might be thinking this patient has a risk closer to a 4+3. that the higher the grade, the greater the risk of microscopic spread. And then when you add a cribriform description of the cells, then that kind of bumps you up a category to a little bit higher risk. All this analysis was developed, as I mentioned before, over 30, 40 years, and was very useful in an era where we didn't have PSMA PET scans. We still look at these factors, but I tend to look first, does the scan show spread? All these issues that we've been using for decades to predict the likelihood of spread, and in my professional opinion, have been superseded by the power of scans to actually look for spread rather than predicting spread.
Well, I think, as you mentioned, it's extremely helpful also in deciding upon treatment, right? Because if you have, as you said, these types of situations, maybe surgery is not the best option. And also, I think a lot of people are wondering if they can do shorter courses of hormone therapy, considering how extensive those side effects are. Now, as far as when I hear perineural invasion and you're talking about it, the cancer growing up the nerve bundles, I'm thinking neural nerve pain. Is there any pain associated with that sort of situation?
None at all. And this issue comes up a lot whenever people hear the word cancer. As we get older, men in my age group, we have aches and pains everywhere. And it's impossible not to, is this the cancer, this ache in my hip or this ache in my groin area? Prostate cancer, unless you've got a PSA of 50 or a Gleason 10 that's really out of control and getting really large, is essentially never associated with pain. So if men are having pain in their groin, it's probably due to prostatitis, which is a type of inflammation that has nothing to do with cancer. And making that distinction, I think, is very important. Pain is signaling something, but it's almost never signaling cancer unless someone has a very high PSA and their disease is completely uncontrolled.
I appreciate you mentioning that. There's so many clickbait videos on the internet saying, oh, if you have this pain, you absolutely have prostate cancer. And I think that's what allows people to kind of wonder, wait, if I have a back pain or if I have some sort of pain, what do I need to pay attention to? And so, they need to go get checked out in those types of situations. But as far as seminal vesicle invasion and them radiating the seminal vesicles, does that affect, the fluid, and does that affect maybe somebody still wants to have a baby? How would that affect that process?
The side effects of radiation have gotten better and better, so that rectal damage is rare, especially with these gel spacers. Lingering urinary problems can be sometimes predicted prior to radiation with things like prostate. The remaining issues, of course, are the risk of erectile dysfunction, which one may try and mitigate with some sort of focal therapy. Even with focal therapy, we're seeing that the primary product of the prostate, which is semen, is often, even with focal therapy, reduced or eliminated when men undergo treatment. Men then can still get erections, perhaps. They can still have orgasms or a sensation of pleasure, but often these are dry orgasms. And sometimes in the shuffle, that doesn't get mentioned, that men need to prepare themselves if they undergo treatment, that they will probably have dry orgasms. I have seen people get people pregnant after prostate radiation. These are typically younger men, perhaps with more robust prostates, and they still have some degree of semen production. I think that in general, men need to expect that they will have dry orgasms after radiation.
So what about in situations with surgery?
Surgery which completely removes the prostate is invariably associated with dry orgasms unless men have an unfortunate complication, which happens in about 20% of men, where they're ejaculating urine instead of semen. That's called climacturia. And this is a side effect that I don't think I've ever seen with radiation, but is relatively common with surgery.
So you had mentioned, that when we see seminal vesicle invasion in a pathology report, that can come up. So how does that come up if somebody is taking, a biopsy of the prostate, and are they actually biopsying the seminal vesicles? How are they getting this information?
More and more, the sequence is when men are noted to have a high PSA, is to move toward doing an MRI before doing a biopsy. And that can be very useful because MRIs are excellent at detecting any cancer spread into the seminal vesicles. And then the person doing the biopsy can confirm or refute that with a biopsy, a needle directed at the seminal vesicles. Seminal vesicles are never routinely biopsied in someone who has a high PSA and goes in for a random biopsy. So if there is a suspicion of seminal vesicle involvement, it could be picked up on an MRI, it could be picked up on a PSMA PET scan. It'll never be picked up on a random biopsy, but it could be confirmed with a targeted biopsy in a doctor who's looking for it.
On this channel, we talk quite often about somebody getting an MRI first and then getting a targeted biopsy. Would biopsying the seminal vesicles in the situation where that cancer does show up possibly on the MRI be an automatic, or is that something they talk to their doctor about?
Well, I think sometimes it's so clear that there's seminal vesicle invasion you don't even need to biopsy them. So I don't think it's critically important. If the biopsy shows that the tumor is located at what we call the base of the prostate, which nonsensically is actually the top of the gland. The bladder sits on top. Then you have the prostate, and the seminal vesicles kind of weave behind the bladder. The observation with a PET scan or with an MRI or both showing seminal vesicle invasion, I think it's reasonable to document it with a biopsy, but it's probably not essential, because if the tumor is right next to where the seminal vesicle is, it's not implausible that if the tumor is located at the base of the gland, that it will start to invade toward the seminal vesicle. And then if you actually see that, if you see the tumor in the base, and then you see invasion into the seminal vesicle with a PET scan or an MRI, you can be pretty certain that there is invasion. And it's not that difficult for the radiation therapist to paint over that area of the seminal vesicle with their radiation and cover it. In fact, the policies are oftentimes to treat the lower third of the seminal vesicles just to be safe. This all is part of the analysis that a good radiation therapist will do in terms of where is the tumor and how big do my margins need to be? Do I need to treat the seminal vesicles partly or fully? Confirmation with a biopsy is actually only in a minority of patients, because it's not hard to see with scans, and it's not difficult to treat with radiation.
You mentioned that you can see the seminal vesicle invasion in MRIs and in PET scans. As you mentioned earlier, that MRIs are excellent at seeing this. How do PET scans work? Is it is it in depth? Is it close? Are they able to see it really well? Or is it kind of like a spot that lights up and they need to look closer? Because usually these are full body scans, right?
Right. I think it's a good distinction. When getting PET scans and MRIs, assuming good quality imaging, which is pretty available if you search for it, the MRI gives much more refined images of the prostate area, and its value for finding spots in other parts of the body is very limited. Whereas the PET scan is fantastic at finding little spots any place outside the prostate and can confirm disease in the prostate or the seminal vesicle, but the resolution of a PET scan in the prostate and around the prostate is nowhere close to what an MRI provides. The combination of the two, of course, is wonderful in terms of getting a sense of where the tumor is, how far it's spread.
So with other like PET scans, though, it doesn't have that same depth and that same clarity of information.
Things like Axemin, choline PET scans, FDG PET scans, and in the minority of men, 10% of men that don't light up with PSMA PET scans, those other PET scans could be useful, but they don't have the same resolution as PSMA PET scans.
I appreciate the clarification, because I think a question we often get is, if PSMA PET scans are so great and they work in 90% of the population, why are we still doing MRIs? And a lot of people want to know, why are we not doing PSMA PET scans before even the biopsy? So I think the clarification that MRIs really get very clear pictures inside the prostate is really good. So when it comes to, different types of prostate cancer, I want to just make sure that we're clarifying to the audience, would Gleason 6 ever, it doesn't metastasize, so does it ever have extracapsular extension? Does it ever go into the seminal vesicles?
It can. Gleason 6 is notable for its incapacity to jump to lymph nodes or bones, but it can get big enough to where it can invade through the surface of the gland. And I think another thing to mention is that scans like MRIs and PET scans on occasion don't see Gleason 6 that well. Sometimes they do, but often they don't. And we don't really look at that as a disadvantage, because Gleason 6, with its incapacity to metastasize, practically speaking, isn't acting like a cancer. It's acting like a benign tumor. And to frighten men with the specter of cancer and throw that name around, even though it technically is called a cancer, is unfortunate. So the fact that the PET scans and the MRIs sometimes miss Gleason 6 is, I think, probably a good thing.
So how often are they missing Gleason 6?
I don't know exact statistics, but I would say at least half the time.
In the situations where Gleason 6 does become large enough where it does go into the seminal vesicles, does it need to be treated in any way?
That's debatable. The issue with Gleason 6 is that as you get these larger and larger tumors, the question comes, is there an area in the tumor that isn't Gleason 6, that maybe has evolved into a somewhat higher grade, The concern always being that higher grades do have a potential to jump, metastasize, and create problems. The management of these men with large volume Gleason 6 is still an evolving art, and balancing out, well, maybe they're getting older, or have other health problems, so we don't need to be that worried even if there is a higher grade, or we also know that some of the higher grade tumors don't metastasize. So there's a lot of variables here that have to do with the conversation between the patient and the doctor, looking at variable risks, perhaps rebiopsying periodically the tumor to see if the grade is stable, coming down to how motivated is the patient to avoid treatment. And as our treatments get better and better, and as focal treatments start to become more of a mainstream treatment, the concerns about side effects from treatment will lessen, and people that want to be more conservative and treat a large Gleason 6 will be attracted to that option. But I don't think there's a clear black and white answer to that issue of how to handle large volume Gleason 6.
So in other types of prostate cancer, we see there's different types of Gleason 7. There's favorable versus unfavorable, 3+4 versus 4+3, and then we have Gleasons 8 and 9s and rarely 10s. But in these situations, are there certain types of Gleason grades that are more likely to have extracapsular extension or have, seminal vesicle invasion, or are they all the same, that they have that potential to go into that area?
Well, as the grade goes up, grade does predict for growth as well as for metastases. The prediction isn't perfect. There are men with high-grade tumors that never metastasize. We haven't developed the skills yet to determine how to subtype those. Not all grade 8s are going to metastasize, but if you compare grade 8s to grade 7s, there's a higher risk of metastasis. And there will be a higher risk for tumor growth, which I think equates with extracapsular extension and with seminal vesicle invasion. I think it's more determined by the fact that the tumor can grow than it has some special capacity. These tumors are often located at the base near the seminal vesicle, and it's just a doorway out of the prostate or at the edge of the prostate where they're just pushing against the capsule. I don't attach a lot of importance to extracapsular extension and seminal vesicle invasion. I pay much closer attention to the grade itself, and then, of course, whether or not the scans show any spread.
So you mentioned radiating the prostate and the seminal vesicles in order to, control the disease. Are there certain forms of radiation that are better than others for this particular situation?
Well, I've stood by the premise that, higher dose, more accurate radiation is better than lower dose, less accurate radiation. And I believe that the doctors that are doing brachytherapy, the skillful ones, are better at delivering higher dose radiation to the prostate than what can be achieved with beam radiation, SBRT, IMRT, proton therapy. That's not to say that you can't deliver useful treatment with these forms of beam radiation. It's just that I don't think they can match the doses that the brachytherapists are achieving.
A couple of men have written in, and they do have seminal vesicle invasion, but they really wanted to do focal therapy because they just wanted to eliminate the side effects. Is focal therapy off the table if seminal vesicle invasion is there?
No, not entirely. The idea of doing focal therapy is, of course, to lower the risk of developing impotence. And the issue, I think, with focal therapy is finding a doctor who really knows what he's doing. It's a tricky proposition to just parse out a section of the gland and put an appropriate margin. I think it is feasible to do focal therapy in men with extracapsular extension or seminal vesicle invasion if their anatomy allows for it, and if that spot that needs treatment is the only spot. Prostate cancer can have more than one site in the gland, and that precludes focal therapy. Sometimes men that have very small prostates don't represent very good candidates for focal therapy, because if you put a margin around the tumor, you end up treating most of the prostate anyway. But no, I don't think that seminal vesicle per se or extracapsular extension necessarily preclude the ability to do focal therapy.
You mentioned cribriform and how it looks different under, the cells in the pathology reports and when they're looking under the microscope at this. Now, to my understanding in the interviews that I've done, cribriform can actually grow in different places, and it tends to be more aggressive, as you said. So in those situations, is the same type of radiation still applicable to that situation, or do they need an extra measure? Is hormone therapy an absolute that they need to get because of the type of cancer that it is?
Well, I think it's two separate issues. One is dealing with what's the likelihood of something outside the prostate. In men that have a high likelihood, hormone therapy or maybe radiation to their lymph nodes is something to be considered. And then how likely are you to be able to control the disease in the prostate? I don't think experts are concerned that cribriform is more difficult to kill than other forms of cancer. It's an issue of possible association with metastasis that grade, cribriform, tumor size are predictive of that possibility of it jumping.
I really encourage you, if you get your imaging results or your biopsy results back and it says any of the terms that we talked about, whether that's cribriform or seminal vesicle invasion, extracapsular extension, perineural invasion, talk to your doctor about what this means for your particular case. And if they are going to treat it, what the possible side effects could be. Am I going to have dry orgasms? Will this affect my quality of life in any way? What type of treatment am I getting? What are the side effects of the specific treatment to the prostate, not just those situations where it is extending. And really, I would also talk about the outcome, because if you're going to live with the outcome of this treatment and you're going to do it on a day-to-day basis, when you look at the side effects and when you look at controlling the disease, you want to hold those as equal. You want to think about your quality of life and getting the disease under control, because you have to live with whatever outcome you are given. And so also in that term, you want to make sure you're picking the right doctors. You want to make sure that you're talking to people who have done, over 500 cases, hopefully thousands of cases where they've treated this type of prostate cancer and that they have had really good results. A really great way to do that is to read online reviews to see if they've published any papers in this area, and even to talk to other patients and support groups on what their outcomes and their experiences are based off the treatment that you're getting. Especially with radiation, I think the dry orgasms part is something that really a lot of patients don't expect and they're not told. And it is important to know about, because a lot of times it can also affect your partner. They have certain expectations. There's an intimacy in your relationship. And when you're getting intimate and then that happens, there's a lot of times a miscommunication. Maybe you weren't expecting it. You didn't know. Maybe your partner didn't know. And this actually comes up quite a lot in my conversations with patients. So the more you know ahead of time of what the side effects could be, the better the outcome. And you can also communicate that to your partner. The number one reason I want you to do that is I want you to feel supported. Having a treatment to such an intimate part of your body, no matter what the treatment is a lot on you. You've already been diagnosed with cancer, and now you're in a situation where maybe it's affecting how you think of yourself. Maybe it's affecting your relationship. The more support and the more you can communicate your needs and what is going to happen and what the expectations are of these treatments and the side effects of them, not only with your medical team, but with your partner, maybe some friends that you are close to, the more support you can get, the better. Now, I'm going to list support groups in the comment section below. The reason I'm doing this is I want you to go to these support groups. You can do it online, you can do it in person, or you can do it through Zoom. And there's even just forums where you can type it in and ask your questions, or you can even read about other patient experiences. But I mentioned earlier, you can find your doctor through that, but you could also find ways on how to communicate your needs with your partner and even hear about other people's side effects and how they handled it. All of this is just a well-rounded way to keep you educated and informed on what's going to happen to you. You are important, and we want to make sure that you're thinking about yourself, your mental health, your emotional health, and your quality of life through this process. When I meet patients in person, one thing that came across to me is just how important your mental and emotional health is. You're going through a lot. So if you need to seek a professional, counselor, you need to join a support group, you need to talk to a friend or a buddy, or you need to call our helpline at pcri.org/helpline. It's a really great way to get the support you need, so please do so. Now, if you need more information about prostate cancer in general, you can visit our website at pcri.org, and also please subscribe to this channel. We have all sorts of new information coming out in this coming year, and we're excited to be able to present those videos to you. The best way to stay up to date is to hit that subscribe button, so please do so. Please remember, most of all, you're not alone, and I hope you have a great week.